So next up, we have the first panel discussion for today, and the topic for the panel discussion is digital health transformation, data and technology. And it is indeed an honor for me to introduce our renowned panelists. Let's start with Mr. Hamad Abdulrahman, Director of ICT Directorate, King Hamad University Hospital, Mr. Leo Leslin, Manager, Hospital Information Systems, American Mission Hospital, and Mr. Gajendira Sivajothi, Data Science Advisor, Mohammed bin Khalifa bin Salman Al Khalifa Specialist Cardiac Center. Hello, Mr. Leslin, can you hear me?
Yes.
Right. So I've already given the introduction to the session, and unfortunately, Professor Miller will not be able to join us today. So I will go ahead and moderate this session on behalf of Mr. Miller. And if you're fine, we can go ahead and start the session on digital health transformation, data, and technology. Right. So we are going to go ahead and start the session. Would you like to give us a quick introduction of yourselves? Mr. Leslin, you can start with yourself
Okay.
and then move to Mr. Sivajothi.
Good. Thank you, Roger. Hi, my name is Leo. I'm representing American Mission Hospital. First of all, thank you very much for having me here. A big appreciation to NHRA and all of you for conducting this event. This is a great initiative. And thank you for having us here and giving us the opportunity to speak. Um, so, Roger, can I go ahead and start off with the introduction, or do you wait for Michael to join?
No, we can go ahead and start.
Okay, so just as a challenge in having this telemedicine rolling out in the hospital, I would like to start off with the three-legged stool, which is applicable for any IT implementation or EMR implementation in any industry, and especially when it comes to hospital. It's a very complex industry which we are looking at. So the three-legged stool consists of people, process, and technology. So I put people as a first because that's the biggest challenge in rolling out any system in the organization. And comes to process and technology. Technology always sophisticated and matured when we receive as a customer or a consumer. But unfortunately, sometimes it comes in pieces. When you look at the telemedicine, it is a telemedicine app. A lot of people embarked on the telemedicine app, but then it has to talk to the other system, which is a core system as an HIS system. Having just a telemedicine app or a technology doesn't solve the entire process. So the process has to be complete in terms of 360-degree, looking at the entire A to Z of the difficulties and then satisfy the objective. So this is on the overall picture of the implementation I'm talking about. But when it comes to the challenges, what we faced as an organization, just a brief introduction of American Mission Hospital. We are 120 years of organization existing here just to serve the community. Our mission is to provide a quality care at an affordable cost with the biblical principle of compassion, grace, and love. And our vision is to be the leader in the health industry. So, coming back to the same question of the challenge what we faced, again it is the three-legged stool, but I would add regulation on top of it. So technology, process, and people, and the regulation. With the technology, choosing the appropriate solution to the organization is a biggest task first. Now, we started off in 2013 with our CEO's help, Dr. George Cherian and Ms. Julia Tovey. They have decided to embark on an in-house system uh, to cater to the need of our hospital. We are a non-profit organization, so We don't want to invest in millions in purchasing the system. So with the zero cost, I would say, we started the system in-house from the scratch, and we are now with the OP and IP completely depending on this HAS system here in the American Mission Hospital. Now, 2019, pre-COVID time, we have released our mobile app in July, which was a great help for the patients. Patients can book an appointment and view the lab report and radiology reports, and even view the prescriptions online without depending on the physicians to call and explain. And that doesn't stop the physician to call and explain. Yes, physicians do call and explain the report, but as a first-hand report, patients can view the reports online through the app. And again, we are spread across Bahrain in 4 different locations. Through the app, patients can actually choose the location and book an appointment. So this saves a lot of time for the patients. So our aim is to serve the patients in terms of many platforms so that they don't call up and waste their time. So many of the calls to the call center is where is the doctor and what time is available, what date is available, and which branch he is located. So these are the basic questions which everyone asks, which is readily available in the mobile app itself. So that's a great help for them. So pre-COVID time, we released the mobile app. And then in COVID, in 2020, January, the COVID hits us. Now there's a big surge of telemedicine which is coming in, where the patients stop coming to the hospital. As you all experienced, the number of patients reduced drastically because of the infection, and a panic coming to the hospital and then getting COVID. So they stop coming to the hospital. Now they have to consult through the telemedicine. So we, as an organization, we also took the measures just like any other hospital. We tied up with the Italian-based company, and then they came up with an app. So we are using the telemedicine app, but it is integrated with our HIS system. Now, here is the question. Now, you can see there are 3 players out there. One, a vendor provides a mobile app. They are matured enough in providing the mobile app. The second one is only the telemedicine app. As you all know, especially in the IT industry, there's so many telemedicine app came up by 2020, 2021 with the startup companies, and then they were approaching us. But not knowing that it's not just a telemedicine app, we don't want to burden the patients installing many different apps. So when we have our own app and there's another app coming up for the telemedicine, then how do we train and explain this to the entire community out there? So there is a challenge there. So this is the second companies or the vendors who are with the telemedicine app. Then the third category is just that wearable devices. Now, how do you stream the medical data through the wearable devices? So when I was in Medica, attending the Medica exhibition in Germany, there are plenty of European companies, they were into the wearable devices. And majority of them are not in the teleconsult, but they support the wearable device integration with their own app. So you have 3 different players out there where they're not connected each other. And we as a customer, as a hospital, have to bring in all of them and connect each other. So that's the biggest challenge we faced in terms of integrating the different app within our HAS system. Now, late 2020 and 2021, Zoom came up with the technology of integrating their system with our HAS system. So we looked at it, but then later we realized that they don't have the payment gateway system, and it fails there. With the APIs and with the proper security encryption, SHA 2256 encryption, we are able to integrate with different systems. And we are now with the telemedicine app. The telemedicine app has our doctor schedule, which is integrated with our HAS system. So anywhere in the world, people can actually use this app and book an appointment, and which will directly reflect on our HAS system. So that's the power of the integration with the REST APIs. So the technology helps here with the challenges what I explained. The second category is the process. The process is, the objective is to handle the telemedicine patients. Now, when we have this app, we have to train our physicians. Physicians are the core stakeholders here. And physicians, call center people, nurses, everyone has to be on board. So the challenge here is the webcams, providing the webcams, trainings, and we have also allocated a dedicated room for them. And these are the logistics where again the challenge we face during the implementation of the telemedicine. When I say telemedicine, in NHRA they have categorized into telehealth, teleconsultation, telemonitoring, telemedicine. So we have a mix of terminologies coming into picture. So when we started, we concentrated only the teleconsult. There's no prescription done on the telemedicine app, although the app supports the medications prescribed through the app. But now I'm touching the third category, which is the regulation. Now, NHRA site itself has these guidelines very clearly outlined, which I think Nitin or the Roger can share that for the audience. This is a policy which is Annex 48, which is already present in the NHRA website, which clearly says about the telehealth requirements and also dispensing procedures. There are two policies which is already present. And especially when it comes to the telemedicine or a prescription, they have clearly laid out three categories. One is the medicines prescribed and what is to be prescribed. Maybe the narcotics and semi-controlled medicines should not be prescribed through the telemedicine app. So these are the guidelines should be explained to the physicians clearly. We don't want to get into trouble, and there are a lot of guidelines which needs to be also explained to the patient during the teleconsultation. Now, in the regulation aspect, again, there are different standards out there in the world. You would have heard about SNOMED CT, Systemized Nomenclature of Medicine Clinical Terms, and CPT, DRG, ICD-10, ICD-11. Now, each hospital has their own systems used, where there's no universal system in place. We have a CPT, we are using the CPT codes, but 90% we are using it. Not that 10% is, our own coding system is used. We are not using the DRG here, but with the national insurance implementation coming on the way, they are already working on the DRG, which we had a meeting with the concerned departments, and they are working on the DRG. We are using ICD-10, though the World Health Organization already released ICD-11. ICD-10 has 66,000 codes. ICD-11 is completely double the amount, 120,000 codes. So the transition from ICD-10, there is no paradigm shift from ICD-10 to ICD-11. It's just an extra diagnosis codes are present in the ICD-11, though it consists of the data structure is the same. But whereas in Bahrain, as far as I know, I'm here for quite some time, I know there are hospitals using ICD-9 still. So from the ICD-9 to ICD-10 is a paradigm shift, I would call it, because ICD-9 is numerical codes and the ICD-10 is alphanumeric. And ICD-11 to bring it took 10 years for the World Health Organization. Unfortunately, we don't have our moderator who is also part of World Health Organization. Mr. Michael is unable to join with us. He could shed light on this more. So ICD-10 to ICD-11, they spent 10 years to bring it on ICD-11. We are working on in Bahrain as well, more than 10 years into streamlining the centralizing the data. We are calling it as a NEMR, NEMR, National Electronic Medical Record, and which is on the way. So we are expecting at any time these models should be applied. As you know, there is a centralized model, decentralized, or a federated model, or a hybrid model, which will integrate with the centralized system. Though we have our own system in place, so we would prefer the decentralized or federated model to be integrated with the government system as well. So that patient goes in any clinic or any hospital, they would be able to see the patient records without missing any of the diagnosis or disease of this particular patient. So these are the core challenges we faced in terms of rolling out the telemedicine. There's one last challenge which I wanted to highlight. I don't know in the audience insurance players are there or not, where the insurance patients are not covered using the telemedicine app. Whenever the patient comes as a teleconsult, there is no signature taken. Normally, when patient comes to the hospital, the patient signs and we send out the electronic claim form to the insurance. So that is an authenticity that the patient visited the hospital. But whereas in the telemedicine app, there is no signature taken, there is no proof that the patient has attended the call. So we need to have certain process in place, or the technology has to support having the signature taken through the app, and then that can be translated and transferred to the insurance companies to have this reimbursed. So so that has to be taken care so that even the insurance patients can be on board. So we had this challenge where we start explaining to the patients, insurance patients, that you'll have to pay because the insurance companies are not going to pay for this. So that's one of the challenges. This is actually burdening the patients as well. These are the core challenges we faced, and on top of this, I would also be explaining on integrating with the value-based care, value-based care on in a few what the scope is. Yes, I
Leo,
will just
I
to
think
take 2 minutes,
yeah.
Roger,
Mhm,
and then I will pass
mhm.
on to the other panelists.
Okay, because there are a few questions for Hamid and Gajendra as well.
Sure.
So we are running short of time.
Sure.
If you
So
could wrap that up in a few
we
seconds.
are looking at a blockchain and AI when we talk about value-based care or streaming the medical data through the app. In the value-based care, there is a cons or the negative is burdening the physicians. There is an overload for the physician to keep looking at the data, and it is not possible. So it can be achieved only through AI to monitor this and then see the pattern and then give the feedback to the patients and what actions to be taken. So definitely AI is going to play a major role in our value-based care. And blockchain is a technology which will also complement to the entire value-based care because it just stores the continuity of the data. There's no manipulation in the data in blockchain. It only has the updated values, and you can track or backtrack who did what. So definitely, blockchain is the way forward in the value-based care as well. Thank you so much.
Thank you, Leo, for your interesting insights on the challenges that AMHS faced in telemedicine, and the technologies and transformations that have come up. Thank you. So we'll move on to the next question to Mr. Abdul Rahman. So can you share any real life scenarios that that you could share with us that drove digital transformation initiatives during the pandemic?
Well, Leo summarized most of it. Basically, with regards to the front end, basically patient care, I think most hospitals has moved to actually applying an application and going to basically teleconsultation for the patients, having that integrated with video conferencing tools like Zoom. For us, it was Microsoft Teams. Uh, our approach was quite different with regards to automation. Instead of relying on AI, we went with robotic process automation, this is RPA. So instead of creating one system that does everything, we utilize the systems what we have currently in the hospital itself, and we configure the integrations to work accordingly to the backend and just coordinate with the payments, with retrieving the information, booking the appointments. All that was done from the backend instead of reinventing the wheel. Uh, One small scenario, which was quite advanced and had multiple factors playing into it, was the COVID test declaration. When COVID hit Bahrain, we were by law specified to actually enter our data into the national system. And as the hospital itself, we tried to thinking of an automated system of handling that. So we thought of, okay, let's use the current email system that automatically sends a notification. Do you have any symptoms? Yes or no. It will send that response through an email. The robotic process automation would email his manager, book an appointment for doing the test, alarming the infectious control department to quarantine that person itself, create a list of all the I would say people that are in contact with that employee throughout that period of 3 to 4 days, and that's completely seamless in the backend. So each day the employee just open that email and just click yes or no. That's it. That integration just happens in the end. That's with regards to digital information from the back end with the healthcare providers rather than the patient providers. Of course, we have the same scenario that Mr. Leo has mentioned with regards to our patients. They were having their appointments online. We had the cameras rolled out. We had the trainings done. We moved to M365 within 3 4 months. But that's seamless for the patients. But for the operations of the hospital itself, there was quite of the problem I think all the hospitals had, which is basically supply chain management, with getting the items on time. I think we all remember the time when we were scrambling around trying to find basically the masks for the for our doctors and nurses just to coordinate and continue their work. Uh, we kind of tackled that by having a supplier portal, which not only allowed suppliers to basically take the load from our procurement of entering their data, but also manage their delivery timings, coordinate with alarms that, well, you have 2 months, 2 weeks to deliver, 1 week to deliver, 2 days to deliver, and kind of shift the priorities on that on the screen itself. So the procurement would know exactly what kind of medication, what kind of drugs they need to actually make sure that they are delivered on time. That's in a nutshell. I could also say, based on our success story, we had a management system of our biomedical equipment on their maintenance. So basically, instead of having to, I would say, a semi-automated process, that system would actually coordinate with the suppliers to basically bring their orders in for the parts if there is any periodic maintenance based on history that we had earlier. So that's completely automated. So we didn't have any crashes during the pandemic, also now itself, throughout that this biomedical equipment was actually deteriorating or was taken out of service.
Thank you. Thank you, Mr. Abdulrahman. Moving on to our next question for Mr. Sivajothi. What are the considerations, a hospital or healthcare organization we need to look into towards achieving a data-driven organization?
Yes. From my point of view, there are four key aspects. Right. We look at the most important aspect is the workflow. Right. It's very imperative that we look at the workflow because it plays a role. It's a blueprint of each operational activities that is performed in the unit or any department within a hospital. Now, when we start looking at this workflow, here comes the next point. What are the value that we're trying to achieve, at least from a data driven perspective? So when we look at the value curve, we start with uh, standard simple reports, right? Basically answering questions like what happened. Then we start evolving ourselves into what is called a descriptive analytics. Here we answer questions like how many, how often, and where it happened. Next comes diagnostic analytics. This talks about what exactly is the problem. Within diagnostic analytics, we sometimes perform what is called randomized testing, right? What happens if we try this? So these are the kind of questions that we are able to answer. Next comes predictive analytics. What action is needed? If we are predicting something, right, maybe with the help of predictive modeling or forecasting, we can answer questions like what will happen next. Now, if we take up a notch from this value curve, we can enjoy what it's called a prescriptive analytics. Now that we know what will happen, what are we going to do about it? What are the kinds of optimization that we can perform? right? So that we can answer questions like what's the best that can happen, okay? Now, I mentioned to you about the second point. The third point, once you have a value curve, now you want to focus, right? You want to have focus areas within this value curve. Now, to answer these focus areas, it can come from various perspectives. One comes from data content growth, right? Basically, what kind of data do you have, right? You probably have basic to advanced data, and of course, you have to align them with the clinical, financial, and operational activities, right? Next comes the analytics competency growth, right? You can either start from a simple and work towards a master level competencies, right? You have an appropriate analytics maturation, right, for individual parts of the organization. And all these things is being empowered by what is called an infrastructure. Do you have the right infrastructure, right, for it? Okay, so you need to, this infrastructure needs to be done in a timely manner. It has to be vendor neutral. So these are the kind of things that you need to look into and consider. And finally, you need to have the data governance growth. I can't stress any more importance on this. You need to have quality data and resource management. And this has to be well aligned with the executive suite, all right, and also the strategic role of the whole management of the organization. And the final part here is the adoption model. Once you have all of this, what is the adoption model that you're trying to practice, right? You may have a lot of systems, but are these systems fragmented? In other words, are they broken apart? Are they not talking to each other, right? How can we integrate them together, right? And where are the data sitting? Do you have, once you have all these fragmented point solutions connected or integrated with one another, next comes the enterprise data warehouse system, right? You have to ensure that all the data is sitting in one hub, all right, and is being analyzed from a data warehouse, right? Once you have a good, a stable data warehouse, you can enjoy what is called a standardized vocabulary and patient registries, right? With that comes automated internal and external reporting. Okay. Once you have this reporting in place, you can enjoy what is called a waste and care reduction. You can optimize your hospitals, right, to identify where the wastages is happening, all right, and tackle them. Only then you can start moving into the analytics component, which is the suggestive, predictive, and your prescriptive analytics. Once you're able to perform this kind of analytics, what I would strongly recommend is to push towards a direct patient analytics with the help of artificial intelligence. So that's like the cherry on top of the cake, right? So these are the four key considerations that we look at, and I look at as part of my role as a data science advisor here in MKCC, right? And this four key considerations is not something that I pull out of the sky or anything. This is in line with the recommendations by HIMSS AMA model, right? So HIMSS stands for Healthcare Information Management System Society, for the adoption model for analytics maturity. So if we look at this from this aspect, right, we'll be able to look at these key considerations, or at least look at them very carefully. That's all I have, guys.
Thank you, Gajendra, Hamad, and Leo. Due to slight time constraints, what we would do is we have a few more questions like the audience would like to ask, but we will go ahead and share them with you, and you could go ahead and answer them, and we will share that with the audience as well. Thank you very much for your valuable time today. I hope all of you continue to enjoy the rest of the summit. And once again, thank you for
Thank
your
you so
valuable
much.
time and insights on this particular
Thank you.
session
Thank you for having
Our
us.
pleasure.
we
Thank
discussed.
you.
Health and trans. Thank you. Thank you all.